My name is John Patenya. I am the moderator for this session. I'm pleased to welcome our panelists here today. Each panelist will have about 10 minutes to speak. I'll be monitoring the chat for any questions. Please feel free to type them in and I will inform the panelists of those questions. Right, so we'll get started here. I guess over to our first presenter, Margarida Pereira.
May I start sharing my screen?
Yes, thank you.
Sorry, wrong one. You're not seeing my presentation, right?
We see your slides, but not in presentation mode.
Okay. Just to make sure.
Yep.
Okay. So good afternoon. I am a health geographer and postdoctoral fellow at the Center for Research on Pandemics and Society. Just let me know, are you seeing the presentation correctly in full screen mode? Because I don't seem to.
Yep, yes, we are. We're able to see in the presentation.
Okay. Oh, sorry about that. Once again, I'm a postdoctoral fellow at the Center for Research on Pandemics and Society, PENSOC. PENSOC is an Oslo Center of Research Excellence that studies the societal dimension of pandemics, both present and past pandemics. I am studying the links between obesity and COVID-19 through a syndemic perspective. So in short, I am interested in understanding the mechanisms underlying the synergies between obesity and COVID-19, in particular, the socioeconomic and demographic aspects in urban areas. This presentation is based on, is based on some preliminary findings from a survey done by PENSOC early on the emergence of the COVID-19 pandemic that included many questions on different aspects of the current pandemic, namely perspectives on non-pharmacological interventions, vaccination, and lockdowns, for example. This work is about the increased risk for COVID-19 in migrant women with obesity. So a little bit of background. Obesity has been declared an epidemic by the World Health Organization over 20 years ago, and regardless all attempts to reverse this tendency, the prevalence of obesity is still increasing in all regions of the world and in all ages. In fact, it has been increasing since the 1970s, and comparing figures from then, the prevalence has more than tripled. Moreover, contrary to what was once believed, high prevalent obesity is not a public health problem only from the developed countries. The last report from the World Obesity Federation states that 15% of all adult population had obesity in 2020, and in 10 years from now, 2030, obesity will reach 20% of the world's population. COVID-19 raised awareness to the obesity epidemic because soon after the emergence of the current pandemic, obesity was considered a risk factor for infection, severity, and even increased chance of death by COVID-19. But obesity and COVID-19 interaction goes beyond the biomedical dimension. The synergies between both diseases are leveraged by social, demographic, and contextual factors that are still underexplored and understudied. Although nearly all countries present high prevalence of obesity, this prevalence is not homogeneous at the population and area level. In the case of high-income countries, evidence shows that the prevalence of obesity is higher in the poorest individuals and among those living in more disadvantaged areas. Not surprisingly, these socially vulnerable groups are precisely the ones that are more affected by infectious diseases such as COVID-19. This is the case in Norway, where immigrants from the more deprived neighborhoods presented higher incidences of COVID-19, as well as higher prevalence of overweight and obesity, according to recent studies. So we believe that numerous sociodemographic aspects or factors that are known to determine population weight status also play a role in the risk of having COVID-19. What research has been showing is that, like in the case of obesity, COVID-19 is also not evenly distributed among individuals and territories. So in a nutshell, minority groups, older population, deprived neighborhoods, and lower socioeconomic groups tend to be harder hit by COVID-19. What we want to know is whether within a population with obesity, the chance of having COVID is even, or does it also depend on the sociodemographic or socioeconomic factors? Our guess is that there are differences of risks even within people with obesity, and thus socioeconomic aspects are as important as the biological and pathological proneness of individuals with obesity for infection in the case of COVID-19. So our main goal in this study was to assess the link between sociodemographic factors and COVID-19 infection in an obese population living in 6 districts of Oslo. More specifically, we wanted to test the risk of having COVID-19 in this population and identify which sociodemographic factors increase the chances of having COVID-19 in this sample. We used primary data from the survey administered in June 2021. This survey was very long and addressed many topics on COVID-19, but we also collected social, demographic, and anthropometric data, namely weight and height, so that we could compute body mass index that allowed for categorizing the sample into underweight, healthy weight, and overweight obesity. So using information on a number of sociodemographic features, we assessed the link between these variables and having COVID-19 using chi-squared tests. And then we computed logistic regression models to identify the factors that were significantly associated with higher chances of having COVID-19 in this sample of individuals with obesity. The sociodemographic factors that we included in our statistical analysis were gender, age, education level, main occupation, job, and migrant status, whether people were born or not in Norway. Data was collected in 6 districts of Oslo that are highlighted in this map by the red squared names of the districts. Over 31% of the sample lived in Gamle Oslo, but the sample was quite evenly distributed by the districts according to the population density of each district. Overall, these districts are populated with more migrants, and housing tends to be cheaper when compared with the other districts. The total number of respondents was larger, but only 4,928 participants provided their weight and height, So for the results, over 53% of the participants had overweight or obesity. From those, 921 individuals were obese, almost 19% of all participants. Individuals with overweight obesity were predominantly men with 45 to 59 years of age, without university degrees, mostly unemployed or depending on social security, and lived in the district of Grorud. No differences were found between participants with overweight obesity and healthy weight regarding having been infected by SARS-CoV-2. In this sample, 270 participants reported having had COVID. From those, most were young, had lower income, stayed home as employment status, lived in Stovner, and were not born in Norway. It is important to say that this survey was administered in June 2021 amid the first wave of COVID-19. So at the time, there were very few cases in Norway overall, and older people were particularly more protected. So maybe this is why in this sample, the younger people seem to have been more infected. In this graph, we can see that except for Stovner, in all other districts, the percentage of COVID-19 cases was higher in individuals with overweight or obesity than in healthy weight persons, although there were no significant differences observed. Findings from the logistic regression models show that in this sample of individuals with overweight or obesity, migrant and unemployed women had higher odds of being diagnosed with COVID-19. Again, considering the moment that this survey was conducted, it is not surprising that being older and retired was a protective factor for having COVID, even within the population with obesity. In conclusion, overweight, obesity alone is not significantly associated with having had COVID, but having overweight, obesity together with being immigrant, women, and unemployed increases the odds of having had COVID-19. This result is what makes us believe that in the case of obesity, the social determinants of health might be even more important than the biomedical aspects when talking about the risk of having COVID, and perhaps other respiratory infectious diseases as well. These findings highly contribute to the debate on how to protect the most socially vulnerable groups, especially in urban areas. In summary, there is a cluster of lower socioeconomic conditions in immigrant women with overweight, obesity in Oslo, which makes them a priority group for public health interventions targeted at controlling COVID-19 or other infectious diseases. And finally, like Dr. Carlos Lora said in the welcoming session, local action is needed to improve urban health, and hopefully this type of evidence contributes to that end. Thank you for your attention.
Thank you so much. While we wait to open the floor for any questions, first of all, thank you for sharing that. I do have one question for you. That's a really interesting study, and I'm curious, what type of interventions do you think would be helpful, either at the public health perspective or what kind of governments or agencies can do to help those most vulnerable populations?
Well, thank you for your question. That's a very interesting question, and in fact is something that we are looking in the literature for right now. I would love to have an answer. I have one idea, maybe biased by my previous research on other aspects of obesity, that I would say that intervention should be multidisciplinary, intersectoral, and come more from a community scale rather than a downstream scale, so to speak. But anyway, that's exactly one point that I am researching in the literature right now. So what kind of interventions should be put together in this syndemic interaction between NCDs and infectious disease pandemics, such as the case of obesity and COVID-19.
Thank you. Looking forward to see what the literature says, and it's
Me too.
Great work to really push that forward. Thank you so much.
Thank you.
We'll move on to our next presenter now, Fernanda Lanzagorta.
Yes, thank you. So I'm gonna share my screen. Do you see my screen?
Yes, thank you.
Okay, perfect. So good afternoon, everyone. My name is Fernanda Lanzagorta, Cerecer. I'm an international consultant on health promotion in the regional office of the Americas in the Pan American Health Organization. So I'm gonna talk about the role of Ministries of Health and in the implementation of the Healthy Municipalities, Cities, and Communities initiative in Latin American countries. I'm gonna explain a little bit about what is this initiative about. So in the region of the Americas, the Healthy Municipalities, Cities, and Community initiative has been implemented over 30 years ago. So it's one of the regions, the WHO regions, who has a long-lasting implementation of this initiative per se. And what the initiative tries to do is to position health in the political agenda of the local level governments by promoting health, equity, and sustainable development through fostering intersectoral action and addressing the social determinants of health. So this is what is the initiative about. And what we did in this research is one of the objectives that we had, it was to identify the role that the Ministries of Health played in implementation of the healthy municipality, cities, and community in Latin American countries. So we have 19 countries that we are considering for the focus on this research. What we did was documentary research of official documents of the Ministry of Health on healthy municipalities, healthy communities, healthy cities, and all the different names that Latin American countries give to local level governments. We also look at mayors' meeting reports and information collected through different regional forums of mayors in the region. We took into account documentation that was dating from the 2000s until today. So a little bit of background of how the healthy initiatives on healthy cities was constructed. So the Healthy Cities Initiative began with the Alma-Ata and Ottawa Charter. And with those two frameworks, WHO Euro started to implement in this initiative in the late 80s. And within that, PAHO started to adopt this initiative with the name Healthy Municipalities, Cities, and Communities Movement. And as a result, there was an adoption by countries of the Americas to implement this initiative from the Ministries of Health level to the local level governments. After the creation of these initiatives in the 90s in the region of the Americas, several regional and global milestones have happened that influence how the Healthy Municipalities Initiative has been evolving through time. So, for example, in 2008, with the Commission on Social Determinants of Health Commission from WHO, we also have the Rio Political Declaration in 2011, as well as a launch for a strategy on urban health in the regional of the Americas. We also had the framework on health in all policies in 2014 that was accompanied by a plan of action for the regional of the Americas. And in 2015, of course, the launch of the Sustainable Development Goals. In 2016, with the Shanghai Consensus on Healthy Cities, that was part of the WHO Conference on Health Promotion. And one of our most recent milestones is the launch and adoption by the member states of the strategy and plan of action on health promotion within the context of the Sustainable Development Goals in 2019. And of course, since the Shanghai Consensus in the WHO 9th Conference on Health Promotion until this date, several forums of mayors have happened in the region of the Americas. So what we found is that from the 19 countries that we consider for this, that were the focus of this study, we identified that 11 ministries of health have a role in the implementation of the Healthy Municipalities Initiative in this category. So we have interventions related to policies and strategies, interventions related to the development of criteria, indicators, guidelines, interventions related to the facilitating of creation of networks at national and subnational level. We also have the role of the interventions from the Ministry of Health in fostering and articulating with other sectors and with other actors. We have city-to-city exchange, collaboration with PAHO, WHO, also the interventions related to financing, to monitoring and evaluation, and to visibility and certification. One thing that is important to notice is that from the ministries that we identified, these 11 ministries, not all of them do all the interventions at the same time, but some of them have they do 6 or 7 of these interventions, and we're gonna explain in more detail in the following slides. So, for example, in the policies and strategies interventions, we found that 10 out of the 19 ministries of health have a policy in place that is implemented through a program or a strategy on healthy municipalities. The name of those strategies and programs varies depending on how the local level government is identified in the specific country. So, for example, here we have Mexico, Ecuador, and Argentina that have a program on healthy settings and healthy municipalities. And we have other countries that have more of a strategy like Guatemala, Cuba, Dominican Republic, Colombia, Peru, Chile, and Paraguay. From the intervention and development of criteria, indicators, and guidelines, we found that 9 of the 19 ministries of health have developed guidelines, criteria, or indicators to facilitate the implementation of this initiative that we see in this purple color on the left side. And regarding of the networks, we found that 6 out of the 19 Latin American countries, 6 ministries of health have a role in facilitating and fostering the creation of networks at national level. And we have, for example, out of those 6 networks that existed, for example, Mexico, Cuba, Honduras, Peru, Argentina, Chile, 5 of them are still active since the 90s. So these networks from Mexico, Chile, Cuba, Argentina, Honduras are national networks on healthy municipalities that have been active and are still active until this day. So they have a long story of implementing this initiative. In the case of the intervention of intersectoriality, so then we found that 8 out of the 19 countries, in 8 countries, the ministries of health articulate with other actors, such as, for example, National Association of Municipalities and other sectors within the national level, such as sector of well-being, education, social development, environment, territorial planning, among others. And as you can see here, like some of these countries we have seen in the other maps, for example, Mexico, Argentina, Chile, Colombia, that they already do the other interventions as development criteria, development of networks, etc. We also found that the Ministry of Health has a role in facilitating the exchange among cities at national and international level. So this is just an example of the different forums where the Ministry of Health has facilitating the participation and the exchange between cities to cities, for example, with the national networks meetings that happen at national level with all the members of those local governments. We also have, for example, the International Conference on Urban Health that we have had participation in the past years, but also this year, for example, we have participation of Chile and Colombia in a session tomorrow as part of a city-to-city exchange. We also have the example of participating in other regional forums on healthy municipalities, such as the one on that WHO Euro organized annually, and other spaces such as with FLAGMA, that is a federation, Latin American Federation of Healthy, Latin American Federation of Association of Municipalities, and also with UNOCC, there is South-South Cooperation, and UNDRR. Another intervention that was that we found was how that the Ministries of Health also facilitate the collaboration between local governments and the Pan American Health Organization, for example, by facilitating the participation of local governments in regional forums organized by the Pan American Health Organization, as well as looking at local governments that could be a good example to showcase as a regional experience, development of case studies, etc.
One of the a minute left. Thank you.
Okay. Yes, I have 2 more slides. So we have also related to financing. This is an example of Chile, of how the Ministry of Health, for example, provides budget to implement this initiative. So 54% of the budget from these initiatives come from the Ministry of Health, and also the countries that facilitate and that the Ministry of Health has a role in monitoring and evaluating the intervention. And as well as we have seen in other slides, here we can see like countries like Mexico, Argentina, Chile, that also give recognition to Ministries of Health if they complete the total evaluation of implementing the initiative. This is just an example of how it looks like the recognition. And one of the, just to wrap up on the conclusion, so we found that we have different mechanisms that contribute to the expansion and sustainability of the Healthy Municipalities Initiative, that also Ministries of Health have a role in articulating with other actors, other sectors. They also have a role in fostering the creation of networks of healthy municipalities at national level. And this is important because all the lessons learned from Ministries of Health that have been implementing the initiative could be useful to strengthen the Healthy Municipalities, Cities and Communities initiative at country level, but also to expand it to other countries in the region who want to implement the Healthy Municipalities initiative. So that's it.
Thank you so much, Fernanda. Again, I am opening up the room for any questions from the audience. I do have a question for you. It's so interesting to gather all that data, and what struck me the most is that less than half of the 19 countries provide kind of support in those different areas. What are, I'm curious to get your thoughts, what are the barriers to kind of reaching in the different countries in Latin America that don't have that support? What are those barriers, and what can be done to mitigate that?
So I think one of the main barriers, it could be like the level of decentralization that local governments have from the national level. Also, between, as you can see, like there are some countries that have most of the interventions in place. So I think it's a combination of different things, like providing technical cooperation, having a strategy at national level that could be implemented at local level, having the compromise or political will from local level governments to also be part of this initiative. And I think also another item that was important was also looking at the financing, where Ministries of Health provide some kind of financial support to implement the initiative. And from the example of Chile, like one part of that budget comes from Ministry of Health, but the other part comes from the municipal budget per se. So I think it's a combination of different elements. That's why there are some countries who have been long-lasting since the beginning of the initiatives in the 90s until this day, have been sustained their action at a local level.
Thank you for sharing that. And we do have one question from the audience. The question is, what about Brazil? They have several cities involved as healthy cities. Could you comment on that?
Yes. So in the case of Brazil, so we look at what was the role of Ministries of Health in implementing this initiative. And in the case of Brazil, they have also a long-lasting history of implementing the initiative at subnational level, but it has been with the support of academic institutions, not with the support of Ministries of Health. So that's something that we can also look at the difference between how that country in specific has been also has a long story in implementing this initiative without the support of the Ministry of Health, just by having partnerships with associations of municipalities and academia that have been the ones who have been fostering the implementation of the Healthy Cities initiative.
Thank you so much. Fernanda, thank you so much. Really appreciate you sharing with us today. So moving on to our next presenter, Rebecca Pradeilles.
Can you see my slides?
Yes, thank you.
Okay. Good afternoon, everyone. So I'm Rebecca Pradeilles, and I'm a global health nutritionist. So in today's presentation, I will present findings on food and nutrition security in infants and young children of female garment workers that we obtained from a remote longitudinal survey conducted during the COVID-19 pandemic and recent political crisis in urban Myanmar. So first of all, what is important to focus on female garment workers and their offspring. Previous studies conducted before the COVID-19 pandemic had shown that women in the ready-made garment factories were highly vulnerable to poor diets and undernutrition, as well as associated health issues, primarily due to poor access to healthcare, but also to little knowledge about their rights in the workplace. In Myanmar, the current political and economic crisis has escalated factory closures and has pushed the country towards a humanitarian crisis. And despite COVID-19 measures that have been put in place to try and alleviate the crisis and poverty related to the humanitarian crisis, it's expected that women who contribute to most of the workforce will suffer a significant decrease in purchasing power, diet quality, and of course, this will have implication for malnutrition. Most interventions that have been implemented in the workplace prior to the COVID-19 pandemic have been mainly nutrition specific. And by this, I mean that they are addressing proximal determinants of nutrition. And these have mainly focused on improving women's nutrition status and consisted, for example, of lunch provision schemes, micronutrient supplementation programs. Overall, the results from this study show positive results and would suggest that the workplace could be considered as a suitable avenue to address malnutrition amongst women of reproductive age and infant and young children. However, there is a dearth of evidence on the effectiveness of nutrition-sensitive workplace-based intervention on the health and nutrition of women and infants in South Asian countries. So hence, the overall aim of our survey was to evaluate the impact of a nutrition-sensitive intervention, which consisted of a cash transfer intervention combined with a targeted social behavior change component on food and nutrition security amongst both female workers and their offspring. However, in today's presentation, I'm going to mainly present findings on infant and young children, and the two objectives of today's presentation are to compare key food and nutrition related indicators between baseline and endline, and to understand the effect of the cash transfer intervention on key food and nutrition related indicators at endline. So to alleviate the complex nutrition landscape due to the COVID-19 pandemic, the Myanku intervention was set up by SEQA in May 2020. And this, in parallel, as I said, there was a small scope of social behavioral change counseling that was implemented to women workers. In the factories. So briefly, because obviously I don't have enough time to go into detail about the cash transfer, but this consisted of emergency mobile money cash support, and the amount of the cash transfer varied according to pregnancy status and age of younger child. So in red, you can see that the amount for non-pregnant migrant female workers and lactating women with a child over 7 months was $40.5 versus $49 for pregnant women and women with a child under 7 months. But several things happened in 2020, 21, 22, which meant that the digital cash transfer was disrupted due to the political crisis. And so in some instances, vouchers with exactly the same amount was used instead of the digital cash transfer. And also due to hyperinflation, the amount was adjusted for both groups, targeted groups. In terms of the study design, and I can go back to that a bit later, due to ethical, for ethical reason and due, to the humanitarian crisis, we could not, have a control group and say that some women would not receive the cash transfer and the social behavior change component. So we adopted like a pre-post quasi-experimental design where everyone received the intervention, the cash transfer, but with different amount throughout the study period. And so the baseline study was conducted in May-June 2021 with a follow-up study, the end line in December 2021, January 2022. The main criteria to be eligible for the study was that women had to be aged 15 to 49 and eligible to the Myanmar cash transfer and nutrition counseling. And of course, fall under these criteria that I mentioned before: pregnant, lactating, and non-pregnant, non-lactating with a child under 2. The target sample was 800. And we adopted like a convenience non-probability sampling technique to recruit women. Due to the pandemic, we had to conduct telephone interviews, and we collected a range of information around sociodemographic, the impact of the pandemic and political instability on livelihood, food security, diets, and nutrition knowledge, attitude, and also household food insecurity. So overall sociodemographic characteristics of the sample were balanced between baseline and end line, apart from child age, working status of women, and area of residence. So at end line, we have a much higher proportion of infant and young children aged 12 to 23 months, which makes sense, but obviously will have implication on some of the results I'm going to show you later. We had a higher proportion of women working and a higher proportion of women who relocated from urban areas to rural areas, but within the same region. So briefly, with regards to the cash transfer received at baseline and end line, we see a slight decrease at end line with regards to the women who collected the money themselves. And this was due to the political instability and women worried about going out and collecting the money due to crime, an increase in crime, etc. in the neighborhoods. But we do see an increase in the proportion of women with control over the money over time, and that increased by 12.5 percentage points. The money was primarily used by women to buy food products, and this was the same at both time points. And after the purchase of food, we had women spend the money to buy for healthcare costs, purchase of medicine, house rent, and purchase of other household items. But the main expenditure was for food. So when we look at food insecurity, which we measured using the food insecurity experience scale, we see that the proportion of households experiencing moderate or severe household food insecurity, which is what you see on the left, decreased at end line. So went from 45.6 to 39%. And that's the probability of severe food insecurity was relatively low and low at both time points. So with regards to infant and young child feeding practices, this slide is really just the raw descriptive statistics before adjusting for any confounding factors. And what we see here is that overall complementary feeding indicators were suboptimal, apart from the introduction of solid, semi-solid, and soft foods, which was introduced at the right time, which is 6 to 8 months. So that was timely, and that was one of the positive practice that we noticed. We also noticed substantial improvements in some nutrition indicators, and these include the minimum dietary diversity, the minimum acceptable diet, minimum meal frequency, but also the consumption of egg or flesh food consumption. However, we also see a worsening in other indicators, such as an increase in the consumption of sugar-sweetened beverages and the consumption of unhealthy food as well, which included savory, fried snacks, and sweet products. So this slide now is comparing baseline and end-line indicators after adjusting for key confounding factors, which are listed below. And we do see significant positive changes for egg and or flesh food consumption at end-line, 0 vegetable or fruit consumption, minimum acceptable diet. But again, despite these positive changes and after adjusting for confounding factors, we do see that the consumption of unhealthy foods and sugar-sweetened beverages also increased among this population. So this slide figure now shows the impact of the cash assistance program which was, as I said, the cash transfer only or cash transfers and vouchers received between baseline and endline on key nutrition indicator with adjusted odds ratio expressed by $54, which corresponded to like 1 standard deviation increase. Yeah. So in what we see is that in children who received higher amounts, where mothers received higher amounts of cash assistance between baseline and endline, we do see that these had positive and significantly associated with minimum dietary diversity, egg and all flesh food consumption, and unhealthy food consumption. But the result for unhealthy food consumption, as you can see, the strength of the evidence is weak as the confidence interval overlaps slightly with 1. So overall, here on this slide, I mean, the cash transfer distributed during the pandemic and political crisis potentially, could have contributed to the improvement in minimum dietary diversity, minimum acceptable diets, consumption of flesh food. But there was also an increase in the consumption of unhealthy food items. But as I said earlier, because of the changes that we see in age, which are quite important, we could also assume that some of these differences that we see are also due to children being older. And it's extremely hard to disentangle the effects of the cash transfer and the age, even if we have adjusted for age, because of the distribution of age not being the same at baseline and endline. It's really hard to disentangle the effect of the intervention, the cash and the age. So I wanted to acknowledge this here. So finally, in terms of key recommendation for program, I think what we see here is that there will be some benefit of continuing the cash assistance and social behavior change to boost children dietary diversity, minimum acceptable diet, and flesh food consumption. However, future efforts should really consider restricting cash transfer to healthy food choices to avoid unexpected increases in unhealthy food consumption, even though, as I said, the strength of the evidence was relatively weak. I haven't presented results on mothers today and women. However, of course, to be able to improve infant and young child feeding practices, we need to go through the mothers and improve their own nutrition and health through the workplace. And some of the intervention or programs that could potentially be put in place could include intensifying nutrition action in the workplace by ensuring, for example, healthy snack and meal program, either subsidized or fully paid for women at nutritional risk. Intensify nutrition action in the community by ensuring that women are able to cook and store foods. And finally, target women at nutritional risk or with low dietary diversity score. And I'm sorry, it's actually cut, but to be able to improve maternal nutrition and hence, I think, infant nutrition. Thank you very much. Thank you.
Rebecca, thank you so much. Such a wonderful presentation. Again, opening the floor for any questions from the audience. I'm curious, so I think you made a really kind of astute observation there that continuing the cash assistance, it has really shouldn't be effective. And obviously there's these layers to the intervention in terms of providing education, as well as making sure that it's going for kind of healthy foods. In terms of a sustainability or kind of long-term solution, what role do you see either the Ministry of Health or kind of other organizations, what would contribute to that sustainability to provide these cash assistance programs to these populations?
Yes, so since we've done this study, obviously, as you can see here, that was funded by both the private sector and the European Union. That was a mix of funding, and since we've done that work, there's been a lot of interest from the private sector, and for example, ready-made garment factories like H&M and other, which I won't cite, but other that are willing to actually invest, in the workplace and invest in women's nutrition. Because obviously that has positive impact for their own, for the company and the production, etc. And so since then, we've been basically, done a bit more focus group discussion with management in the in the different factories to try and understand, what the, factories are willing to do and how much they would need and what support they would need. So from a human resource point of view, like for example, having someone employed to do some kind of like nutrition education session or health, awareness campaigns, or distributing documents combined with, as we said, either providing, so because the cash system, as you say, in terms of the sustainability is always hard because it's depending on funding, isn't it? So I think one option would be to really provide meals perhaps for pregnant women and lactating women, and also provide support. So within the factory, for example, having breastfeeding rooms or having like childcare centers within the factories for women to still be able to breastfeed their children throughout the day for exclusive breastfeeding, continued breastfeeding practices that we want to promote. So these are some of the things that we're currently looking at. And the private sector, there's actually quite a big interest from the private sector to invest to try and improve women's, well-being within the factories. So yes, I'm not sure if I fully answered your question, but with regard to sustainability of cash transfer, it's always unfortunately dependent on funding. And as you said, either the Ministry of Health deciding to do that, or maybe the private sector coming in and trying to, yes.
Thank you for sharing that. It's such a complicated factor. So I appreciate you sharing your thoughts. Thank you so much. So on to our next speaker, Benazir Patil. And Rebecca, if you could stop sharing your screen.
Yes, sorry. Yeah.
Thank you so much. And Benazir, let us know if you're able to share your screen.
Yeah. One minute, it's not showing.
No problem.
Is it showing now?
Yes, thank you.
Now it's in presentation mode.
Yes, it is. Thank you.
Yeah. So my presentation is going to be a little different because we as an organization work with older people, and we work in urban slums in India. And I will just walk you through quick what exactly our organization is all about. So we have a longish name, Society of Community Health Oriented Operational Links. It's called SCHOOL. In short, we work towards achievement of SDG 3, good health and well-being. And we have a flagship initiative which is called Vriddha Mitra. Vriddha in Hindi means old, and Mitra means friend, so friends of older people. And our vision is basically, to have wholesome, secured and dignified lives of older people. And we basically aim to build an age-friendly ecosystem for the older people in India. And we have seen, and we have done a lot of analysis. We started with this initiative in 2018. And we know that there are socio-cultural challenges, economic challenges, psychological challenges with older people. And there is definitely a fear and stress of being dependent on other people. So our program strategy basically focuses on reaching the elderly directly by establishing community-based mechanisms. And since we have started with the bottom of the pyramid, we do it in urban slums and remote villages. We create champion spokesperson who can speak for the elderly. We create livelihood options for the elderly. We collaborate with the government at all levels. We build linkages with varied other stakeholders, specifically for social security entitlements and schemes. So at the moment, we are working in 86 slums across the country, and in 65 slums in Pune city. And these are some of the highlights, that we have 63% females and 37% males. 8% elderlies are living alone. without any family member. 12% are living alone with their spouse. 14% have any kind of pension, and 45% of total older people have some kind of illnesses. 44% have what you say communicable non-communicable diseases, and 68% have one single chronic illness. 32% have multiple illnesses. So we started with 2 slums in the city of Pune, and this study is all about those 2 slums, which we initiated in January 2019. This is basically how we work with the older people. Our first objective is all about creating social support structures at the community level. So we work with the elderly, their families, and the community as a whole, specifically to sensitize them and create volunteers. We also do a lot of service delivery ourselves. We bring a lot of services from outside at the doorstep of the elderly, and we also link them or refer them ahead, including escorting them to different health facilities for higher level treatment. We also build a lot of linkages, as I mentioned, for social security entitlements and schemes. So we focus on enhancing social inclusion. Now, all our activities, interventions are based on the quality of life domains that WHO recommends. So these are 6 domains: physical health, psychological state of mind, level of independence, social relationships, environmental aspects, and spiritual concerns. Spiritual concerns are largely about whether the elderly feel being loved and cared for. So our individual care plans are basically addressing all of these 6 domains. And so our study is all about measuring the improvement in quality of life for these vulnerable older people that are residing in 2 slums of one of the zones of Pune city. And our objectives are basically to understand whether we've been able to make a dent. Because the whole idea or the whole premise of our interventions is that everything that is happening in the lives of elderly is on the decline, whether it is their vision, whether it's mobility, whether it's hearing, and their sense of independence. All of those are on decline. So our efforts are continuously to make and ensure that we improve the quality of life, rather than, we can't reverse the situation as we can do in growing children, uh, because they have crossed the age of 60 years. So in 2 intervention slums, our study questions largely pertain to what has been the improvement in the state of physical health, nutrition, and other needs. What has been the improvement in the level of psychological, mental health, and emotional needs? Have the project interventions helped in improving the level of independence among the older people? What degree of independence the elderly population have been able to achieve? What has been the improvement of social and interpersonal relationship? And what degree of involvement and forms of participation by the elderly population in their surrounding is achieved? So we largely had qualitative tools that we administered. So the method was a combination. In quantitative assessment, we have just one checklist which is administered on the elderly. And apart from that, we've also looked at the baseline data before we started the intervention. So, and we spoke to a number of community leaders, senior management members, members of referral organizations, the corporation, the municipal corporation, and families of older people, and the beneficiaries themselves. So these were our 8 different tools that we administered. The findings basically pertain to, so we've kind of divided the findings into 4 domains. So if you see improvement in physical health, there are regular home health checkups at their home level, and there are checkups at the community level. So regular health checkups and continuous monitoring of blood pressure and sugar levels have improved the early stage diagnosis of both hypertension and diabetes. Frequent home visits improved continuum of care. by ensuring uptake of medicines and other health services, counseling about hygiene and monitoring hygiene of bedridden patients by the field coordinators improved the hygiene level significantly, also increased the hygiene among older adults and their family members. We in COVID, we started with virtual consultations versus physical ones through our specialist doctors, and this also helped in resolving. So this basically served as primary health care, and this also resolved minor ailments. A number of supplements and ration, meaning either raw ration or cooked food, helped in meeting their nutritional requirements. And supplements pertain to calcium, iron, multivitamin actually reduce their problems of joint pain or feeling better than earlier. It also helped in improving their strength, immunity, and overall health of the older adults. So provision of basic medication suggested by the virtual OPDs and medications for hypertension and diabetes helped in keeping a check on this non-communicable diseases. Oh, it's stuck. Can you see? Psychological health. So yeah, so frequent home visits, again, continuous interaction improved their overall mental well-being. Counseling with the family members and neighbors also resolved a lot of conflicts, because there's a lot of communication gap between the family members. De-addiction counseling of older adults also is there, but not much has been talked about in this study. Conduction of activities like group discussion, exercise session had a perceived positive impact on mental well-being of older adults. Some elderlies also reported that getting services like assistive devices, diapers, etc. also became the reason to be happy in life. Some mentioned that this helped in having a dignified life. Frequent bouts of anger, irrational irritation of older adults was reduced because of the kind of support and counseling sessions. Then arrangement of excursions, trips, get-togethers, and competitions helped in reducing stress, improving mental health. Provision of various services at home and improvement in health made them happy. With regard to improved level of independence, a lot of assistive devices are provided to the elderly specifically to improve their mobility, their hearing, their vision. So this also increased their self-confidence. Again, I would say that this mention is again made here that hygiene improved because of provision of diapers. And so it boosted their confidence to get included into the society. Same thing with nutritional supplements, because it increased their strength and their balance to walk independently. A lot of physiotherapy is provided in the project area, starting from the community level to geriatric units where they get equipment-based physiotherapy. So it has also helped in improvement in activities of daily living, and self-care has also improved. And this also improved their muscle strength, bone health, and reduction in pain, both physiotherapy and nutritional supplements. Social.
About 1 minute left. Thank you.
1 minute. So yeah. So social relationships also improved because community leaders also contributed to increase confidence levels. They reported participation in a lot of gatherings and talking with each other. So this helped. Counseling of youth and older adults had good impact on their family relationships, or what we can say intergenerational bonding. And overall relationship with family members, relatives, and neighbors also improved. So just to add a little more, that since the project is all about networking with many organizations. So for example, the organization has an MOU with the municipal corporation as well as with 25 odd organizations that provide a lot of support through referral services, and these are free of cost. So this actually helped. Let me just take you to the actual unmet needs. So one of the things that the elderly talked about was the financial security that they look forward to. they are also very keen to adopt income generating. They want to participate in income generation programs so that they can generate a little bit of income. And yes, a number of elderly said that 60 years and above is an indication of old age, but there are many around them who are 50 years and above, and they would request for similar kind of care for starting from 50 years and above. So this was one of the recommendations that came from the beneficiaries. So I'll take a pause here and have your questions.
Thank you so much for going through that. And first of all, such great work that your organization does, and to really assess that quality, those quality of life indicators. Thank you so much for sharing that. We do have one question from the audience. How were key stakeholders of the communities engaged in this process?
So in the first place, we register the elderly through an application, a software that we have, which is called Saving Life Checklist. So we enter the slum. We start talking to, we start having community meetings. We start talking to people, to understand what are the challenges overall in the community, and specifically if they understand anything about the challenges of the older people. So it's a lot of group discussions initially when we are entering the slum. Once we enter the slum and we decide that this slum is very, very vulnerable and we want to work with elderly living in these slums, we start registering the elderly and developing their care plans. But there are three pillars that we work continuously with. The elderly, we empower the elderly to speak about the challenges. We talk a lot to the family to make them understand what are the challenges and how they should address it. And thirdly, we involve the community through community meetings, through screening sessions, through a number of camps that are held. So there are cancer screening camps, there are eye care screening camps, orthopedic screening camps. So we involve community as volunteers in these screening camps. And we also engage them as volunteers when there is a elderly who is bedridden. So some bedridden who are living absolutely alone, so they have to be provided with diapers, medication. There should be medicine reminders for them because they can't read English, they don't understand what medicine is to be taken at what time. So in different ways we engage volunteers. And one of the things that we've realized is that many volunteers actually come forward and they start approaching us, especially when there is a bedridden in their house and that person passes away. They suddenly feel that, okay, we as outsiders were working for so many months and years with them. Now it's their time to, start serving others. So that is also one of the ways how the volunteers come forward.
Thank you so much. And we have one more request. If you could type into the chat the website for your organization, if you could put it into the chat for others to share. Thank you. So next we have William Lodge.
Hello, let me just share my screen. Okay, does everyone see my screen? The presenter mode?
Yes,
all right, perfect.
Thank you.
Hello, I'm William Lodge. I am a Gathered Fellow, which Gather stands for Global Alliance for Training in Health Equity Research at Drexel University, and I'm a PhD candidate at Brown University in the Behavioral and Social Health Science Department. So for today's presentation, I'm examining, or this data that I'm examining is self-rated health and gender and informal settlements in Belo Horizonte, Brazil. Now, Belo Horizonte is the 6th largest city in Brazil with a population of over 2 million and 19% of the people living in informal settlements. Many factors such as high crime, the lack of access to safe water, poorly structured houses, and overcrowding can lead to poor health outcomes. Understanding these factors is essential to know how people living within these informal settlements perceive their health. Now, self-rated health can be defined as, an individual's overall perception of their health. Self-rated health has been predictive of mortality and morbidity. And a recent study, well, not so recent, 2006, there has been a study conducted in Brazil, but states of states, capitals, and federal districts. And in the study, they found regional, sex, and educational level inequities were observed and perceived poor self-rated health. They found that poor self-rated health differences among women. Although the study was instrumental in understanding factors associated with self-rated health at a surveillance level, it doesn't specifically examine socioeconomically deprived neighborhoods as we define as informal neighborhoods or settlements. The importance of examining these vulnerable neighborhoods, it'll provide evidence that can directly impact the health system and strengthen it rather than a gross generalization. So our research question was the association between gender and self-rated health in these vulnerable neighborhoods in Belo Horizonte. And then the second one that we were interested in is what are the gender differences between health-seeking behavior, diagnosed mental conditions, and non-communicable diseases. Now, the data that of this analysis is off of Villa Vida program or project, which was a series of structural interventions in informal settlements in Belo Horizonte. The intervention encompassed a period from 2006 all the way to 2002 all the way to 2012. There is a qualitative part of the study. However, the data presented today is only using the household surveys, which was conducted between 2017 and 2018. The questionnaire domains were demographics, self-rated health, evaluation of health services, perceived characteristics of living environments, and other social determinants of health, lifestyle, quality of health, and perception of the intervention. The household surveys were administered in Portuguese and then translated in English for this analysis. Now, how we define poor self-rated health, we have it in two parts, which is pre-intervention and post-intervention. So in pre-intervention, it's in this year blank of pre-intervention in general, how would you evaluate your health? And then for post-intervention, at the time that the survey was taken, today in general, how would you evaluate your health? We operationalize poor rated health as those who reported bad or very bad. So this is showing you a table, which I know is a little busy at the moment, but it's only looking at the significant social demographic characteristics by gender. So the analyzed sample was around over 1,000 participants. Women were more likely to be dependent on the public health system. Men were more likely to be married, while women were more likely to be widowed. In our sample, we also found that women were less likely to be employed and more likely to make less than the minimum wage than their counterparts. Now, we also were interested in non-communicable diseases and their health utilization, right? And so we found in our analysis that women were more likely to be diagnosed with hypertension, depression, and having two or more of the following non-communicable diseases, such as heart disease, diabetes, hypertension, and depression. However, given the high rates of non-communicable diseases, women were reported seeing their doctor more than men were. And this might be an issue of just that's why they're diagnosed with these diseases more than men, because they're actually engaging within the healthcare system. What then we're interested in is that we know that women are engaging in the healthcare system. We know that they're being diagnosed with these certain non-communicable diseases and mental health conditions, but we wanted to see, well, then, is there a difference in perceived health, self-rated health? So we conducted multivariable logistic regression to investigate the difference in self-rated health and gender. In both models, the bivariate and the multivariate, we found that women were significantly associated with higher odds of reporting poor self-rated health pre-intervention and post-intervention, even when adjusting for age, race, income, region, intervention group, and any diagnosed non-communicable diseases. It is important to note that the magnitude of self-reported health was reduced from pre-intervention and post-intervention, which might suggest that the structural interventions that took place were helpful, but more work is needed to be conducted to understand the issue facing women in these informal settlements and how it impacts their perceived health. Now, in conclusion, women rated their health worse than men, even though they are more likely to access healthcare than men, even when controlling for socioeconomic class, race, and comorbidities. The results of this analysis are consistent with a recent study of 114 Latin American cities, which found that women rated their health worse than men. However, men feel a strong decline in their self-reported health as they age. Our results reflect an interplay between the social and structural inequities faced by women in these informal settlements. Even though the magnitude of self-reported health reduced after structural intervention, more research is needed to understand the reasons for differences among self-rated health and the ways to increase the perceived quality of health among women. Possible research areas to explore might be the length of time women are living in these informal settlements, informal occupation, or kind of responsibilities of and also looking at responsibilities of the family might give us some indication on these differences in perceived health. For acknowledgements, these are the co-authors that I'm working with in Brazil, and the funding for this secondary analysis is the Gather Fellowship at Drexel University. And so I just want to thank you for your time and opening up for Q&A.
William, thank you so much. I'm again opening up the floor for any questions. So we do have a question from the audience. As women reported poor health status, does the study consider violence among women?
Yeah, so in our study, we didn't control for violence. There is a study that uses this data that does look at violence in particularly, and women are faced with violence on how they kind of measure or operationalize it. But in this analysis, we didn't control for it. But I think that's a really good point of something to kind of look into and to kind of explore further.
Thank you. First of all, thank you again for that presentation. Really interesting study. And I'm curious to get your thoughts on, because you mentioned that the intervention itself, could you repeat the Viva?
Villa Vida project. Yes, it was, project. Yeah.
I'm curious what, so kind of now with the results that you found, in what ways do you think that the program could be either altered or kind of adding different components of the intervention to again address that component of increasing kind of that self-rated health among women?
Yeah, so with this intervention, it was a structural intervention. I like to think of it more of a beautification of the slum rather than kind of getting within the community. And so I think in future interventions, rather than kind of building roads or building, access to water or like building kind of closer health centers, or all of these things kind of increase diagnosis of kind of health conditions and have people engage within the healthcare system more, it doesn't really get to that kind of behavioral mechanism of like, well, why is my perception of health still low or poor? And so then I think an additional intervention will have to be more at the community or kind of individual-based types of interventions might benefit rather than these kind of beautification kind of structural interventions, which this intervention was.
Thank you so much for sharing that.
Yeah.
Thank you, William.
Thank you.
On to our next presenter, Sega Stock.
Hi, I will share my screen. Okay. Is it visible?
Yes, thank you.
Okay, thank you. Good evening from Turkey. I'm Sega Stock. I'm an instructor at the Department of Architecture at Bilkent University in Ankara, Turkey. And my co-author, Cenk Çakırcalı, is one of my undergrad students actually at the department. And today we will present you the findings of our quite modest study compared to the other studies actually, which we conducted as one of the preliminary steps we are trying to take towards further larger projects actually. So we would appreciate any kind of feedback from the audience. The issues of mental health and urban health are still rather unexplored in many developing countries. Such places, in means of both their societies and governments, overlook these phenomena and fail to create environments that enable and enhance the well-being of their people. Turkey is actually one of those contexts where mental health is still a taboo, both among the society and also for the institutions, for the government, and this situation renders the problem rather invisible, thus it leaves it confined to be unsolved. Within urban societies, senses of belonging, safety, security, hope, freedom seem to be missing, especially for the youths, which actually who constitute the future. So we believe that working on the youth is quite important when it comes to mental health and also urban health. So we would like to start with very brief information on our context. Turkey is a country with 82 million population, and it has been ruled by the Conservative Party, AKP, for the last 21 years. We are mentioning this because this caused kind of excessive power gained by the government, and it resulted in many problems such as monopolization, polarization, injustice, bans, violent interventions, demonstrations, femicides, etc., which actually created this kind of unsafe, uncomfortable environment for many of the youth. And the country actually has lowest life satisfaction among OECD countries, according to OECD's 2020 report. And the Turkey's young population is actually one of the highest in Europe. And in Turkey, within Turkey, life satisfaction among the youth is the lowest compared to other age groups, and it actually is showing a falling tendency. And in Turkey, actually, 77% of the population is urban population. So that's why we think to be able to kind of provide a healthier environment for the youth, we have to talk about the urban environments and urban health more. And this issue is kind of an unexplored realm, especially coming from our areas of expertise, urban design and architecture. So to kind of draw the context of our city as well, we come from Ankara and we studied in Ankara. The city lies in a central position and it's the capital city of Turkey. It has been witnessing many heavy road and settlement constructions in the last 30 years, but in a rather unplanned way. It still is continuing to grow. And actually the city, although it's the capital and although it's the city of universities and everything, it ranks the 17th actually in Turkey's well-being index. So we can say that its position is quite low compared to the large cities of many countries. So in this study, what we aimed was to kind of initiate a research in relation to urban mental health and the youth to guide our further projects, which we hope to get funding for. And here we interviewed 20 young people within the university, which were between the ages of 19 and 24. The interviews involved questions on respondents' mental health, perceived quality of life, and satisfaction with Ankara. So it's more like an exploration. So we're not going to talk about many statistics and everything, but we will present you some kind of qualitative interpretations out of this data, which would be found to be significant for further studies. Actually, most of our respondents said that they liked Ankara. All of them, of course, live in Ankara. And actually, one of the reasons why they didn't like Ankara, not one, but three of the reasons, the most common responses were lack of activities and events, problems with public transportation, and lack of urban system due to uncontrolled urbanization. The reasons why they liked Ankara was the order and the comforts within the city, which they seem to be related to each other in their perception, their social connections with their friends, families, and everything, and the fact that Ankara was constituted a habitude for the respondents. And we also asked them what changes would they make to Ankara. I mean, what changes would make them like Ankara more. And actually, we had two repetitive answers. One was more events, cultural entertainment events, and the other one was better transportation and urban accessibility. We can actually say that this transportation issue came after and after. So was a response at many levels. So we can say that actually transportation networks in Ankara in urban planning is actually quite important to provide multiple things, which I will mention in the following slides. We also asked them if they felt safe in Ankara, and actually most of them mentioned that they did, but the ones who said that they didn't feel safe in Ankara mentioned the crowd and people. They felt threatened by crowds, for example. They also mentioned constant presence of security, because in Ankara, for example, you can easily see policemen, soldiers walking on the streets, and some streets are controlled and everything. Although they are to provide security, actually they do not provide a sense of security, let's say, for the youth. Some of them mentioned high crime rates, which might be right or wrong, by the way. Some things might be just myths that they kind of believe in. The behavior towards females, we can say harassment, for example, is a very common problem in Ankara. So for many females, for example, walking in the city can be quite problematic, especially in the evening, at night and everything. And also they did mention the unsafety in public transport, which is again kind of related to the previous issue that I just mentioned. And kind of in maybe related to this or not, we don't know, but most of the youth said actually they spent their leisure times at home rather than outside, which we found to be quite interesting actually, considering that our kind of the research population was constituted by middle high income students in a way. And they of course mentioned cafes and bars as well, but the frequency of mentioning of home was quite, we found to be quite interesting. We then asked them some questions about their mental health, and at first we asked them if they felt comfortable if they thought that it was comfortable to talk about mental health within the context of Turkey. And actually 90 of our 20 respondents said no. So that's why we can actually, it kind of supports our argument that mental health is still a taboo within the society. And actually they do request and they do advocate for talking about mental health further, and they do call for the professionals, both health professionals and also the government, to care for their mental health more. And also they did complain a lot about society, which kind of, refuses to listen to them or acknowledge their mental health problems and everything. And also actually 12 of our 20 respondents had different mental health issues. On the right, you can see the different issues that they have stated. Depression, anxiety were the most common ones, actually. So we can say, and we, as an instructor among my students as well, it's quite easy to observe that, especially after the pandemic, this number kind of increased. And we do encounter a lot of young people who are dealing with different forms of mental issues. But of course, still, I find something quite positive here as well, which is that the young generation is more open to speaking about these and being open about their own mental issues, which I think makes the issue more open to dealing with, let's say, for the governments and for the official bodies, let's say. Then we asked them if the physical environment had any effect on their mental state. Actually, we realized while we were asking the questions that they didn't really think about it that much. So it also shows some sort of unawareness of this relationship among the youth, but also kind of reflecting the situation within the society as well. But once they were kind of prompted to answer this question, they did mention a couple of things, like, for example, improper too much lighting triggering their mental health issues. But the ones that were more common were lack of social areas and interaction, actually. Therefore, again, problems with public transport, which actually they consider to be causing isolation from their friends or from the public spaces. And also lack of green spaces where they could kind of find some sort of relief, and also lack of aesthetics in the built environment, which kind of causes some discomfort.
So we have about a minute left. Thank you.
Oh, okay, sorry. And they did, in line with these, they did suggest some improvements to their environment. And actually they mentioned some of the items which actually relates to their freedom as well. So kind of the transportation was again an issue that was pointed out in a very significant way. And they actually rated their quality of life quite fine. 6.5, I think, was the average. And again, for this, it was similar to the previous findings. They wanted more interaction, more events, more spaces for social relationships and social events, cultural events, and also kind of betterment of public transportation was again an issue that was emphasized over and over again. So I will just very briefly say a couple of things about our discussion. So in Ankara, in the city, actually public transport seems to be one of the fundamental problems, which actually maybe unexpectedly for some creates problems for the mental health of the youth by preventing them from being mobile within the city. The respondents were also kind of concerned with the quality of public spaces and buildings as well. So actually architects and planners need to be aware of this situation, because it somehow, although it might be indirect, it has influence on the mental health of the youth. And yes, it's not just the planners and the architects or else can solve the problem. Actually, they do realize that the government needs to provide a more free space, a space of freedom for the youth as well, so that they can feel more free and easy to socialize and everything. Because actually in an urban environment, it is not only a physical environment, it's also a social environment. So social production of space is very important to create better relationships between the youth and the urban environment. So the government has a lot to do as well, not only in means of developing the physical spaces, but also in means of creating better cultural, socio-cultural environments. So through this study, this was a small step, but in the future we hope to expand these such research to kind of create more collaboration and hopefully to solve problems within our context. Thank you very much.
Thank you so much. That was such an interesting study. So there's so many layers to this, and I have so many questions for you. There's, as you talked about, there is this cultural taboo around discussing mental health within Turkey, and part of the recommended solutions here is to have government involvement to say like how to improve the urban environment, how to provide quality public spaces, improve public transit to as a trickle-down effect, right, to ultimately help that mental health, for youth and for other populations within Turkey. I'm so curious to hear your thoughts on how can we, what is the next step? What is the conversation to have with government officials or ministries of health, or, to take action in this, since there clearly is a connection that the youth have talked about.
Thank you. Yeah, thank you for the question. Actually, it's a question that I have for my community as well. Actually, coming from our field, it's kind of hard to bring these issues on the table, let's say. But what I'm trying to do with my students, with my master's students, to at least raise awareness in the youth, so that even if I can't do it, they can do it. That's why I involve one of them, for example, in each of my studies. But I would say, at least, for example, the next step that I'm going to take is to try to take funding from a governmental institution. So which might actually create a dialogue, and actually sometimes when people are faced with, or when they come across such issues, they do listen to you, and they become much more aware of the situation. I think at the moment, our main problem is not being aware of the situation. That's why I kind of kept on repeating this awareness issue over and over and again, let's say.
Yeah, really, really fascinating work. I look forward to hearing what the next steps are and what can be done, because this is absolutely an important issue.
Thank you.
So thank you for presenting.
Thank you.
So next we have Angela Freitas. Is Angela present with us today? It's like Angela has 2 presentations. I don't see Angela on the attendee list or the panelists list. We also have Anika. Is Anika present with us today?
Yes, hi, I'm here.
Hi, Anika. It looks like Angela's not here, so if you don't mind going next, that'd be very appreciated.
That's just fine. Let me, I'm just messaging my co-presenter who was about to get on as well, just to make sure he can join.
No problem. I apologize if I recognize it's going about 20-ish minutes before anticipated. So thank you for that flexibility.
It's just
And I encourage our attendees, if there are any questions that you'd like to ask our great panelists here. We're learning so much together today, and I am so appreciative of this conference and to bring all of the different work that you all bring, and just allowing us this opportunity to discuss and to learn from each other. So thank you for being here with us today, and please feel free to type in your questions into the chat.
Can everyone see my screen just fine?
Yes, thank you.
Okay, fantastic. Great. So my name is Anika Wickramanayake, and I am representing Jacaranda Health. We're a private sector nonprofit working in the field of maternal health in Kenya. My colleague who is about to join the call as well and will take us through some of the presentation findings is Michael Johnson, who's representing the Berkeley Air Monitoring Group. And today we're happy to present to you our findings on air pollution exposure amongst mothers and newborns in Kenya's informal settlements. So in our presentation, we'll take you on a journey starting with an introduction to the environmental and social context for the study, onto our research methods, our results, and finally a discussion of outcomes and recommendations based on the findings of our research. The setting of this work is focused on Nairobi's informal settlements, and this is because we know that the vast majority, in fact, 70% of the population of Nairobi live in such informal settlements. And it's well documented that the maternal and newborn mortality rate is higher in these settlements, much higher, with the maternal mortality ratio standing at about 2 times the national average, and the under 5 mortality rate at about 53% higher than the national average. In informal settlements, the health landscape tends to be even more fragmented and unregulated, which drives these unfortunate statistics. And so for this reason, gaining a deeper understanding of the drivers of such poor health outcomes is crucial. There are several root causes that affect a mother's health and well-being in the informal context, such as poor health infrastructure, unregulated health services, low water and sanitation coverage, high air pollution, limited access to basic health information, and limited knowledge amongst providers, particularly emergency obstetric and newborn care providers. And all of these factors act in confluence. However, they are often discussed or introduced in silo. So at Jacaranda Health, we decided to bring together a coalition of local partners on a 3-year implementation research project, which was funded by USAID, which is called Kuboresha Afya Mitani, with the goal of studying all of these factors in tandem to gain a deeper understanding of the full picture of a mother's experience. And today in particular, we're going to present to you our research, which focuses on air pollution as a factor that may be contributing to poorer health outcomes within the context of the broader maternal and newborn health ecosystem. The reason we included air pollution exposure in our work on the maternal health ecosystem is because globally, it's well known that there is a correlation between higher exposure to air pollution and poorer health outcomes for the general population and for mothers and babies. Nairobi is particularly at risk. So we've seen from previous studies that the ambient particulate matter measured by PM 2.5 is 2.5 times higher than World Health Organization standards. And we also know that air pollution is a cause of deaths in mothers and in young children. But what we don't yet know is what personal exposures are like in informal settlements. And we have even less information on what the potential drivers of air pollution exposures are. Therefore, the goal of the study was to understand the environments in which moms and babies are more likely to be exposed to particulate matter in the urban informal settlements, and to determine which factors are more associated with increased exposure, such that we can make recommendations for interventions and policies that can help mitigate exposure. So moving into our methodology, we established a sampling frame of all the households in 2 particular informal settlements in Nairobi. They're called Kawangware and Mathare. These were selected with the help of county officials. And the sampling frame was all the households in these 2 informal settlements that had mothers who were pregnant or had given birth within the last year. We identified these households with the help of community health volunteers because of their close community linkage and access to the population. We then selected a sample of moms, stratified by neighborhood, and screened them for willingness to participate in our study. In total, 71 women were successfully enrolled, and they were monitored for PM 2.5 exposure, as well as their location using GPS throughout the course of a normal day. I'll now hand over to my colleague, Michael, to take you through some more methods and results.
All right, thank you, Annika, and go ahead and keep the screen yours. I'll just say next we want to advance slides. So another note just on the methods with the sampling, this was done during the COVID-19 pandemic when there were lots of lockdowns. We had wanted to get 100 participants, but because of COVID and some of the restrictions, we had to end sampling a little bit early. So just a quick note on that. I'm sure other folks have been dealing with similar issues. So a little bit more about the methods. We use purple air monitors, which some of you might be familiar with. They've been launched all over the world. They're low-cost monitors that have been really well characterized against reference methods. And we were lucky that we had a reference PM 2.5 monitor in Nairobi that we calibrated the response against. So that was a very fortuitous just circumstance for us. But they do real-time PM 2.5. And we put them inside of this backpack insert. So every participant got this backpack, and there's just an insert with the purple air along with those GPS loggers, which also recorded their location minute by minute. So we were able to look at time resolved and location resolved data over time while they're wearing these backpacks for a 24-hour period. And then we cross-reference that with surveys. So next slide. So getting into the results a little bit. So one of the things we wanted to do was to see if there were any hotspots to identify, because if we were seeing high exposures associated with any locations, maybe we could go back and see if there's something happening there with an industrial source or an activity where we could potentially have an intervention, either reducing that source or maybe changing paths that people might be walking, or other behavioral interventions to avoid exposures at those hotspots. We didn't see anything that was, I don't know, really clear. We've highlighted a few areas in the two communities where we did the sampling in Strehe and Dagoretti. But again, there wasn't anything that looked like they were just clear hotspots. I think at some point we might want to go back and look and see if there's something happening in some of these areas where we've seen some of the higher concentrations. But again, there wasn't anything super clear. We'd say, okay, yeah, something's happening in this area that makes us think these are really high exposures that we need to mitigate. So, we took a look at that, but again, it was maybe suggestive of a few places, but not clear. Next slide. All right, so what do we see kind of overall? So some of the big picture stuff, these plots show the exposure concentrations at home and then away from home. And on the left for these box plots, that shows when people are away from their houses, and on the right, that's when they're home. And it was kind of interesting to see that we saw higher exposures in both these communities for the participants when they're home versus away. We thought maybe it would be reversed, because when you're outside the home, you might be exposed to more dust and particulate matter from traffic and other sources, but the reverse was true. So there are things that are happening in the household that are elevating exposure, and that in itself is an interesting result, because that makes us think we might want to focus on ways to mitigate exposures inside the house, not just what's happening kind of generally or when people are outside their homes. Next slide. All right, so this is a plot that shows the average concentrations over time in both of these communities, and there are a couple of things to pull out of this. So the personal concentration is that teal color, and then the ambient concentrations, which we also measured, is the kind of that orangish red color. And you can see for both those different samples, the ambient sampling and the personal sampling, you get this very typical diurnal pattern where you have higher concentrations in the morning and higher concentrations in the evening with a little dip in between. But what we're seeing here is that in the evening, those personal concentrations are substantially elevated above the ambient concentration. So that's what that boxed in area shows. And so this might be related to what we just showed before, with higher exposures being observed inside the home. So something's happening inside the home where exposures are being elevated. And so, some of the common activities or things that might be happening inside homes, especially in the evening, you think cooking, use of kerosene lamps for lighting, and other activities where there might be some sources inside the home, use of mosquito coils, for example. So all those could be driving exposures higher inside the household. But, it's interesting, also gives us an opportunity to dig deeper and maybe identify some of these sources of exposure. The other thing to point out here is we put a line where the WHO interim target 1 is, and most of the samples, most of the personal exposure samples were above the WHO interim target. So again, just generally reinforcing that people in these informal settlements are exposed to concentrations that are above the interim target. And again, that's just the interim target. It's not what the WHO has deemed as a safe level of exposure, which is actually 5 micrograms per meter cubed, which is a very stringent level. That's something that's almost nowhere in the world it adheres to, but we're nowhere close to that in these areas. So certainly just generally concerning that these exposures are so high. Next slide.
So you have about a minute left. Thank you.
All right. Okay. Well, I'll just be very quick here. So again, we did dig into those surveys a little bit, and just highlighting a couple of things here quickly. Things we saw that were associated with higher exposures were use of wood stoves and charcoal stoves. You can look at some of the other things we saw in the homes, but again, that aligns with what we were seeing in those graphs. And then one more slide here, which shows that we also saw that exposures were higher for people who are walking compared to other modes of transport. Just again, maybe that highlights a place where there could be a potential intervention, thinking about mitigating exposures for people who are walking to and from work or other errands. All right, and I think I'm going to hand it back to Annika now. I know we don't have much time, but hopefully can zip through the rest of the discussion.
Great. Yes, just to very quickly wrap up, as Michael very well explained, there are several ambient sources that impact mothers' exposure to particulate matter, but the most significant one in the informal setting was at-home exposure. So therefore, we recommend a couple of potential areas for intervention. Number one being reducing exposure to at-home pollution by introducing cleaner fuels for cooking and household activities. There are already several initiatives around this, such as use of electric cookers and other fuel sources, and making them more financially and geographically accessible. These initiatives have a lot of potential to limit at-home exposures to pollutants for mothers and their households. And this is particularly important to think about access to these things in the informal settlements. But for longer term solutions, lowering ambient pollution will require really a lot of government and community cooperation. Nairobi City Council have already committed to tackling air pollution via a number of acts. But even more advocacy efforts should be prioritized to incorporate environmental solutions when thinking about maternal, newborn, and child health. Under this project, we utilized multi-stakeholder forums to bring together various actors in the MNCH field, and we really recommend this as a solution as well as other cross-sectoral approaches. So overall, the bottom line being that environmental exposures will affect a mother's health in her pregnancy and postpartum journey, particularly in urban settings, and is therefore a factor that we should consider and prioritize when addressing MNCH.
Thank you, Annika. Thank you so much for presenting such really interesting work. And again, I welcome folks to ask questions in the chat. I have a two-part question, if that's okay, because it really just got me really curious. From in a short-term perspective, what are kind of barriers to, whether it be barriers to access or barriers around kind of cultural feasibility and acceptability around those short-term uses in terms of cleaner fuel sources within the home, et cetera. So that's part one. And then part two of the question would be, what are those barriers for long-term in terms of government and multi-stakeholder collaboration and engagement? What are the kind of political barriers and or kind of challenges within that?
Yeah, fantastic question. And I would say that honestly, we need to delve into this with a deeper research study. So number one, we would need to understand from the personal level and the household level, what are those barriers to access to these cleaner fuels? It's definitely, what we can hear anecdotally from our work in the community is that some of these fuels are not accessible, not as easy to access, not as cheap, or not perceived as the preferred method just because of history or traditional use. So getting that to be a more acceptable and appealing source of fuel is something that we should really delve into, maybe with some qualitative research to understand what are those barriers and what could be done in order to address that. Then in terms of the longer term barriers and needing to get various stakeholders involved in reducing ambient exposures, that's a really important question. And like I was saying, Nairobi's already made certain commitments to tackling air pollution, which is great. But I think the reality of then implementing those when it comes down to county levels can be challenging. And so maybe involving a lot more of the lower level stakeholders in that decision-making process would be key. And as we were saying, the maternal health landscape doesn't typically look at air pollution or ambient exposures like this. So getting those players and those actors to be a part of the conversation when those policies are made could actually really help with shaping those policies such that they are better prioritizing moms and babies. But then also there's the challenge of being able to unlock the finances that are needed to really make those long-term changes. And that's something that's beyond my expertise for sure, but also one that needs a lot more discussion and a bit more data behind it, I would say. Michael, if there's anything you want to add, feel free to jump in.
Yeah, maybe just a little bit on the household energy side, because that's what I work on mostly. There has been a fair amount of work looking at some of those barriers for transitioning from charcoal and wood to fuels like ethanol, LPG, electricity. And there have been lots of concerns about some of those kind of cooking practices that are perceived as different to traditional methods. But generally, what we've seen in the literature and from the studies we've done is that if you provide people with an option that is easier and convenient and cheaper, people are going to go for it, whether or not it is different from their traditional cooking practices or not. The issues around how food might taste or how food is prepared, those generally fall away when you have something that's really easy to turn on, is less expensive, is convenient. We did a big study with LPG stoves in rural areas, which was a big change from using 3-stone fires and traditional wood stoves, but people loved their LPG stoves. It helped that we provided LPG and the stoves for free, right? That people just thought that the fuel was great. They weren't using their traditional fuel. So I think if you give people a better option, then they're going to use it. And that doesn't mean that there doesn't need to be research to figure out how to make that transition happen as quickly as possible, especially in contexts like these, which haven't been studied as well, the informal settlements. But if you give people an option that's easier, less expensive, convenient, it's usually pretty compelling to transition. But of course, that's not easy to do. So that's the second part of the question that Annika was touching on as well, right? Providing that solution is not a straightforward or simple task. So yeah.
Thank you both for sharing that. Such important work that you're both doing. We have about 9 minutes left to the session, and I'm just doing a last call for Angela Freitas. Angela's on the schedule to present. If Angela is present with us today, please let us know. I want to thank all of the presenters today. I've learned so much, and I think that one of the major themes that I've kind of gathered from all the presentations today is that everyone has done kind of research in their respective kind of domains and areas of the world. And it also highlights this need for long-term kind of planning, collaboration. It's so layered and so complex in terms of the health interventions, the urban health interventions, working with governments, working with ministries of health, both in terms of responsibility as well as kind of how can we make an impact for the people that we are here to serve and to really understand. So I want to thank everyone for presenting their work and really making this their work to really acknowledge it and to really share that with not only folks with this conference, but folks that are interested in these spaces. In our last kind of few minutes here, if there's any final comments or things that any of the presenters would like to share, I'm opening the floor for that. Well, presenters, thank you again. I'll be emailing all of you so that we can kind of get each other's contact information and kind of stay connected and see what everyone's doing beyond this. Truly, truly appreciate your time to be here at the session, to be here at this conference. I hope everyone has a good rest of the evening. Thank you so much.
Thank you.
Thank you.
Thank you. Bye.
Thank you.
Thank you
Take care.
so much.